Welcome to Washington Hospital Today, dedicated to informing residents about healthcare topics and issues. Through programs featuring community forums and free health and wellness classes, our goal is to empower community members with the information needed to make informed health decisions. Washington Hospital has been providing healthcare to the residents of the Washington Township Healthcare District for the past 60 years.
Hello and welcome. Today's presentation, Interventional Radiology for Vascular Disease, is presented by Dr. Amrit Hansra. Dr. Hansra is a vascular interventional radiologist with Washington Hospital's Interventional Radiology Center. Dr. Hansra earned his medical degree from the Ross University School of Medicine in the Caribbean with further training in UCLA. Without further ado, please welcome Dr. Hansra.
Thank you guys. Thank you for joining. Really appreciate it. My name is Amrit Hansra. I am a vascular interventional radiologist here at Washington Hospital. And today we're going to be talking about a few different things, and mainly peripheral vascular disease and venous insufficiency, venous reflux, and venous disease in general. Now, the scope of today's discussion, let's start off with what is interventional radiology. It's not something that is quite known throughout even the medical establishment. It's not something that's easily ascertained from the name itself, say like a pediatrician or a surgeon, OBGYN. So we'll talk a little bit about that. What is vascular disease in itself? We'll go over that as well, and the differences between arteries, veins, and what kind of ailments can affect either or. So let's start off with what is interventional radiology. So we actually utilize state-of-the-art imaging to help diagnose and treat ailments throughout the body, quite literally from head to toe. Everything that we perform is minimally invasive. There are no open surgeries, which makes for shorter recovery times. The catheters, the wires, everything that we're using is basically less than the size of a number 2 pencil that you may have near you. Also, what I stated before is we quite literally treat from head to toe, meaning any sort of intervention within the vessels, arteries, or veins from the neck down, from the toe up, wherever you may find it, we can get in there from a tiny pinhole either through the wrist artery or through the artery in the groin. Also, we do quite a few percutaneous procedures as well, where we're not actually getting to arteries and veins themselves, but we can insert probes, needles, anywhere throughout the body, either takes tissue sampling, we can burn tumors, and we can do a whole slew of other interventions percutaneously. So these are an example of the types of vascular procedures that we perform. Hemorrhage embolization. For example, if somebody were to get into a car accident here in 84, 880, and their spleen is ruptured, they have some internal bleeding. Sometimes, yes, the patient does need to go to surgery, but oftentimes they can actually come to our angio suite, which is real-time x-ray, aka fluoroscopy, and we actually get into the exact artery that's supplying the bleed itself and coil it off with very tiny coils. What's the recovery time from that? Well, from the procedure itself, about 2 hours. Prostate enlargement. Men, do you suffer from enlarged prostates? Do you see yourself running to the bathroom frequently or not voiding completely? Well, this is something we can handle as well. Intra-arterially. It's not an open surgery. Again, we can get our tiny catheters and wires down into the artery supplying the prostate and embolize those arteries, causing the prostate to shrink. Uterine fibroids, similar type of process here. Liver-directed chemotherapy and radiation. So this is actually a very complex and widespread type of procedure that we perform, where basically any sort of tumor that's in the liver, let's, for example, talk about hepatocellular carcinoma, HCC. Now, instead of systemic chemotherapy, patients that are appropriate for this type of treatment, we can again get into those little arteries and directly supply the chemotherapy or the radiation to those tumors. So essentially, those systemic side effects aren't there. Knee osteoarthritis. Let's kind of go up a little bit further to that, which is something I'm very passionate about, is everybody has knee pain, whether it be from just old age, walking around, wear and tear. Well, what are the treatment options? One, you can just take your NSAIDs, your ibuprofen, your Advil, your Tylenol, and try to rest. You can ice it every once in a while. You can maybe get some injections into your knee. And then what's the more extreme options? Well, you can go to surgery and you can have that knee replaced, whether it's partial replacement, complete replacement. And those are usually the two extremes of this disease process. Well, what's something that we can perform? It's actually called genicular artery embolization. And again, I know this is kind of a common theme that I'm mentioning here, but we can get those small catheters, those small wires, into the artery supplying the knee, and I can actually embolize the inflammation of the knee, thereby reducing the pain. Very exciting, something we do offer here at Washington Hospital. So if you continue forward with all these lists of different types of procedures that we perform, specifically we can talk about other procedures that are pertaining to this talk, with deep venous thrombosis and pulmonary embolism. And we'll get over the difference between the two. We'll go over those and why interventions need to be performed. And when you talk about those two, I do have to mention IVC filter placement and removal. Now, you may be wondering what this means, a bunch of fancy words, but I guarantee you, if you've been watching TV late at night and those infomercials may talk to you about, have you had an IVC filter placed within the past 10 years? Well, call this office. Yeah, and that's actually essentially true because you need to get that IVC filter removed. It should not be permanent. We'll go over that as well. Venous reconstructions, dialysis fistula creations and maintenance. We can talk about mesenteric ischemia, epistaxis, fancy word for nosebleeds. Do you have recurrent nosebleeds? Well, that is something that we can offer as well. Yes, you know I'm going to say it, a recurrent theme, small catheters, small wires into the arteries feeding the nose, and we can embolize those as well. Hemorrhoids, I bet you didn't know we can do that. It can be a pain in the butt sometimes, but we can embolize that as well. We can get into those arteries and we can shut them down too. So what are the different types of vessels? Arteries and veins. In general, arteries carry oxygen-rich blood from the heart to the tissues of the body. And I say in general because somebody may be out there who is saying, wait a second, what about pulmonary arteries? And we'll talk about that. Yes, pulmonary arteries are named arteries, but they're not oxygenated blood. And that comes handy when we're talking about pulmonary emboli in a bit. And veins, well, in general, veins carry deoxygenated blood from the tissues back to the heart. So essentially, arteries away from the heart, veins towards the heart. So arteries, and why is this important that we're going to talk about two different types of vessels? Well, arteries are thick-walled and they do have 3 layers involved. And they are prone to atherosclerosis. And what is that? That essentially means plaque formation, usually with age, underlying diseases. We'll go over the list of kinds of basically typical underlying diseases that we face in this type of setting. And veins, slowed venous flow can ultimately lead to blood clots, thrombus formation. That is especially important right now during COVID times. We talk about, well, blood clots. And it may be due to vaccines, but also we've seen this quite frequently over the last year because we're just leading more sedentary lives over this last year. We're not out as much. We're sitting on our computers more. We're doing Zoom. So that's something that I've seen a uptick in the last year, and we'll talk about that as well. So let's start off with the arteries. Remember, the 3 layers prone to atherosclerosis, and this can lead to peripheral artery disease. Okay, atherosclerosis is the accumulation of lipids and fibrous material within the arterial walls themselves. And this mainly, when we're talking about this in this setting, it's affecting the lower limbs. Yes, it can also affect the brain and the heart, and those are a little bit different, so we're not going to be covering that during today's talk. We're going to be talking about more of the legs. And this can lead to a loss in extremity muscle mass and exertional pain. Well, what does that really mean? You may notice over the years, you start off at a young age, you're feeling pretty good, you go for runs. Over time, diet gets a little bit worse, you may start smoking, and then you may start noticing, well, I used to be able to walk a good amount. I could easily go a couple of blocks. I could go a mile, no problem. Well, maybe now after 2 blocks, I'm starting to notice some pain. And that pain may occur in the back of the calf, around the feet, maybe the thighs. And then you say, well, that was weird. So let me take a rest. Let me sit down for a little bit. And about 10 minutes later, the pain's gone. Well, that could be a problem. That could be related to peripheral vascular disease with something that we call claudication. Okay, and if you look over on the screen on the right, these are kind of the steps of peripheral artery disease and the severity of what you may experience. Claudication, what we just talked about. Rest pain, maybe you're just sitting there and actually you're not exerting yourself and you're still having that pain. Well, that would be rest pain. And then what can that eventually lead to? Well, ulceration. And why is this happening? Essentially because there's a lack of blood supply now down to the lower extremities. It may be a toe, it may be a foot, the whole foot. It may be actually an ulcer on the side of the leg. And what happens when there's a lack of blood supply? This can eventually lead to gangrene, infection. And that's something that can be potentially irreversible. This is a quick schematic of what a normal artery should look like. Those green arrows you see, basically the blood flow is going down, it's going through that bifurcation, no problems. Well, in PAD, aka peripheral artery disease, you can see that yellow plaque built up on the sides of the walls, and guess what's going to happen? You're going to have a lack of blood supply, and you can see that the green arrows actually not coursing down to the other side anymore. In peripheral artery disease, you can see there's a direct correlation with age, and yes, it's over time. It's just something that happens over time with age. But because of the underlying diseases that can concomitantly be a part of a lifestyle, smoking, diabetes, hypertension, that's why you see this wear and tear over time, and there's this nice correlation to the older you get, the more PAD you might experience. So what are these risk factors that we're talking about? I've mentioned a few. Smoking is a big risk factor. Dyslipidemia, what is that? Well, it's basically abnormal accumulation of lipids within the blood. And this is something you talk about when you go get your lipid panel done. You look at your LDL, you look at your HDL. You want HDL high, you want LDL low. So those are kinds of things that you need to be thinking about. Diabetes, this is big. And why does that happen? Well, because your blood vessels pretty much aren't normal anymore at that point. Hypertension. When you just constantly have that high blood pressure hitting those arteries, it's going to cause some wear and tear inside the arteries themselves, and it's going to cause some of the plaque formation. Obesity, and then genetics. Absolutely, there are certain populations that are more prone to developing peripheral artery disease. So what are the symptoms? We touched upon a few of them so far, but PAD is oftentimes asymptomatic. You may not know you even have any atherosclerosis buildup within your arteries. Therefore, it's difficult to detect. You don't really detect it until you say, well, my leg hurts and I don't know why. Let me go to the doctor and try to figure it out. We see CT scans quite often of patients coming in for something else completely, maybe checking for a kidney stone, maybe checking for the liver. But then we start seeing that atherosclerosis built up in the arteries themselves and the big artery down the abdomen called the aorta, and then incidentally down into the bifurcation, the iliac bifurcation, which are the arteries that are starting to supply either end of the legs. So claudication, again, we talked about that, which is cramping, pain, and weakness in the legs, and especially the calves on walking that disappears after rest and is usually associated with the inadequate blood supply to the muscles. You may start noticing that your muscle mass has starting to decrease. No matter how many times you go to the gym and start doing those calf raises, it may not be working anymore because you have a lack of blood supply. That nutrients, those basically that energy that needs to go to those muscles, it's just not there anymore. Patients oftentimes have difficulty keeping up with family members, and they will end up kind of walking this shuffling gait where they just can't get these nice big strides like they used to. And it's more of a, I need to slowly get to where I need to be because they're having this pain. When left untreated, what happens with PAD? Well, it can progress to critical limb ischemia, aka CLI. And this is defined as basically ischemic rest pain and then lower extremity wound. So you have a lack of blood supply to the legs, then you develop a wound. Well, how should a wound usually heal? That's the oxygenated, nutrient-rich blood that should go to the wound and help the body naturally heal. Well, what happens when you don't have that nutrient-rich blood anymore? You're going to have a wound that's not going to heal. So it's not really chicken or the egg. You need the blood to make that wound heal. CLI is responsible for the majority of non-traumatic amputations in the U.S. So let that sink in for a little bit. If somebody didn't have a car accident, somebody didn't have an accident for whatever reason, but they're coming to the hospital because of a non-healing ulcer, this is the number one cause of a non-traumatic amputation, is CLI, something you may not even heard of before this. So if we look at kind of an algorithm here, and you have a population aged 55 and older, and you look at asymptomatic about 10%. Then you have the intermittent claudications, 5%, and the critical limb ischemia over here at 1%. And you can see this nice kind of diagram of what is usually the outcome in these type of patients of greater than 55 years old. And you may be looking at those three letters right there called ABI. We'll talk about that in a second. And this is a quick and easy test that you can ask your physician in the office, say, is this something you can perform in the office right now? Or can you refer me to somebody who may be able to perform this for me so I can really see, do I have this issue that we're talking about right here? PAD affects 8 to 12 million people in the United States. And 1 in 20 Americans greater than 50 years old suffer from PAD. So again, you may be completely asymptomatic because that's actually the most common symptom is asymptomatic for PAD. But that doesn't mean that you don't have it. There may be something down the line, and maybe 5 years from now, 10 years from now, that may set it off and cause you to develop that rest pain or that ischemia, that non-healing ulcer. Compared with somebody who has a normal glucose tolerance, aka let's talk about diabetes. Somebody who is diabetic, okay, there's 30 to 40% of those patients suffer from PAD greater than 50 years old, as compared to somebody who's not diabetic, and that was about 10 to 20% of patients greater than 50 years old who suffer from PAD. And this is a quick map of basically the United States ranging from 1995 to 2014. Essentially, the darker the blue, the more diabetes that's prevalent in the United States. We won't go over as far as why diabetes is more prevalent these days, but just know the statistic that I just talked about, the more diabetes, well, it directly translates to the more PAD is prevalent. So as I click through this, you can start seeing the more and more blue that appears throughout the United States. Yep, that's diabetes. And you can look at the state that you reside in right now, and you can say, well, look at California, just popped up blue out of nowhere, so we need to do better for ourselves. Peripheral artery disease, what should you be asking yourself, okay? You're listening to me talk about this right now, and you may be sitting there going, well, how do I know I have this, okay? Well, do you feel any pain in your calves, your thighs, the buttock region, or the hips with exertion? And I'm not talking about going to the gym, you're deadlifting 300 pounds, you're squatting 400 pounds, and then the next day your lactic acid is pumping through. Not that kind of pain. I'm talking about you're just walking through the grocery store and you're carrying that, I don't know, a couple of jugs of milk, and all of a sudden, hey, you know what, my legs are starting to hurt. I need to sit down, I need to find a bench, I need to relax for about 5 to 10 minutes, and then I'll get back to it. Do you ever experience any of those symptoms? Do you feel any of these symptoms while just laying in bed? Let's forget about the grocery store. Let's forget about everything else. You're just laying in bed and you say, well, why are my legs hurting right now? Why is it the back of my calf? Why is it my buttock region? That may be a little clue, so start thinking about that. Are you experiencing any skin discoloration or temperature changes in your legs? Well, what happens when you have a lack of blood supply to a certain area? Okay, well, obviously the lack of blood is there, so you may not be as warm in that area, okay? People may notice this with their fingertips, but again, peripheral artery disease, when we talk about it, it's more in the legs. So do you notice that you have to have a couple of pairs of socks on at all times? Oh, you always have to have your feet inside some sort of blanket. Yes, I know there's a lot of people that this is just normal for them. I'm not talking about those people. But when you put those temperature changes or skin discoloration, and you combine that with the first two things that I talked about, with that pain, the calf pain, the thigh pain, the buttock pain, now you really need to start putting a picture together that this may be PAD. And do you have any sores on your legs that just won't heal? You may tell yourself, well, you know what? I bumped up against the cabinet about 2 weeks ago. Yeah, I bled a little and, something happened. I put a Band-Aid on there and you kind of forgot about it. But then now that you're listening to me talking right now, you may say, you know what? That wound is still there. Why is it still there? It should have been, 2 weeks old. It should have healed up by now. There should have been a nice scab. So start looking around. Questions to ask your doctor. So you have made the conscious decision. Yes, I feel like I know some of those symptoms exist for me. Yes, my legs hurt, my butt hurts, my hip hurts. Yes, I need to go to the doctor and I need to figure out, is this really PAD? Well, questions to ask your doctor. First of all, are your medications optimized? Is your hypertension, your high blood pressure, is that truly under control? Is your diabetes truly under control? Okay, you need to start, do you have a statin Is your lipid panel under control? So you need that's number one, absolutely number one. If you don't have that lab work or you don't have those vital signs written down and you haven't checked them maybe in years, that's not step one, number one. So start looking into that. Also, ask your physician, do you mind examining my legs? We examine legs all the time, whether it be for diabetic patients or somebody who suffers from PAD or venous disease, which we're going to talk about here in a second. So basically, what are we looking for? We're looking for pulses, number one. You have a few pulses on your foot and behind your ankle that are two big telltale signs that if they're absent, something is going on. And it's an arterial-related likely issue, okay? We're also looking for the sores. Do you have any sores that you just can't see? Maybe behind your leg, under your foot, that you just really can't see, and it's hard for you to examine. We'll take a look. And then what are, some non-invasive tests that you can perform to really detect PAD? Say, I don't want a surgery, I don't want anything invasive, I just want a quick answer. Do I really have this or not? So we'll talk about that in the next couple of slides. And then what are your treatment options? Say, you know what, it is positive. You do have PAD. Yes, your rest pain or your claudication or your ulcer or your temperature changes in your legs, yes, that is related to bad blood supply to the legs. Well, what are your treatment options after that? So non-invasive tests. Let's go over that. I mentioned these three letters earlier, ABI, ankle brachial index. This is a very, very straightforward thing that can be done in the office. It is completely non-invasive. Essentially, you have a blood pressure cuff that it gets inflated over the arm, and then another blood pressure cuff that gets inflated over the ankle. It's basically as it states, ankle and then brachial, which is over here in the arm, and it's an index. And all it's doing is comparing the blood pressure from the ankle compared to the arm. And if you see, there's a little chart right there on the top left of that little schematic that says if it's greater than 0.90, you're normal. But if it's 0 to 0.4, well, you have severe claudication or severe obstruction. You need to start thinking about something to do. Essentially, anything less than 0.9, that means there's some sort of obstructive process that's going on in the arteries. It doesn't have to be completely obstructed, but there's some narrowing going on somewhere. Again, very straightforward thing that can be done in the office. Takes about 10 minutes. Ask your physician about that. Yes, we do this in the office as well. And then let's go to the next slide, which is a CTA. And what does that mean? Well, this is essentially a CAT scan. We inject some contrast dye through the IV. It gets circulated throughout the body, and then we just take some images of the legs. And you can see here on the image that essentially these are the arteries that are supplying the bilateral thighs. And you can see the nice kind of radiopaque lines or the bright lines, but then you see these scattered really bright areas. That's all plaque, okay? So we can judge how much plaque is in a certain area of the artery. Is it truly obstructing the area? Does something truly need to be done at that point? Say you don't want to get a CT scan because of radiation. Well, we can perform a similar type of scan with MRI, and this is done completely without radiation. So this is actually a nice MRI image of the legs down in the calf regions. This is a pretty actually normal image of what we are looking for down in the legs. You should have 3 vessels essentially going down towards the ankle. This is another quick and easy test called a duplex ultrasound. And this is an ultrasound, okay? It's, everybody's familiar with an ultrasound, whether it be for gallbladders, for the heart, for OBGYN issues. It's just an ultrasound that goes over the body. We take a look at the legs, and we're essentially looking at the waveforms. And these waveforms tell us, oh, you know what? It looks like there's an obstruction here. It looks like there's some narrowing here. It looks like the blood's not as good in this region. So again, this is a nice, quick, and easy test for us to perform on an outpatient basis. So let's talk about a minimally invasive test. And the reason I say minimally invasive, because yes, again, everything I do is minimally invasive. There are no open surgeries here. But this is essentially an angiogram of the foot. And when I say angiogram, a lot of people immediately start thinking about the heart. It is a very similar process. I don't deal with any angiograms of the heart. Those are for cardiologists specifically. But anywhere else throughout the body, I can do an angiogram. And this is specifically in the ankle and the foot. And we would like to see these arteries supply the back of the foot, which is on the right of the screen, and then the front of the foot going towards the toes. So we would like to see a nice kind of line, and this is contrast dye, by the way, that you're seeing these black lines. So everywhere those black lines are going, there's good blood supply there. So how can an interventional radiologist help? Well, number one, we need to do a detailed physical exam. It absolutely starts from a good history and a detailed physical exam. Is this pain of the legs truly from peripheral artery disease? Is it from venous disease? Is it from neuropathy or radiculopathy? Something we do quite often here actually is dealing with back pain. Is this because of that? Order and personally interpret appropriate imaging. That's key. We deal with, again, because we not only treat the areas that we see on imaging, we actually interpret the imaging ourselves, okay? So we order, whether it be a duplex scan, a CT, an MRI, we tailor these imaging specifically to each patient. And then we intervene when indicated. Again, everything's minimally invasive and it's quick recovery time afterwards. Usually for these types of procedure, it's a small pinhole, again, less than the size of a number 2 pencil next to you, through the artery in the groin, and we can enter our wires and catheters through there. And we'll look for those areas that we saw, whether it be on CT, MRI, ultrasound, and we'll say, yep, there it is, I found it. And we can put in little tiny balloons in there, open that up and say, well, did the balloon fix it? Perfect, it did, we're done. Or I guess it didn't fix it. Let's put a little tiny stent in there. So we have many different options. We have other devices that essentially are little tiny vacuum cleaners for the arteries that we can put in there and then suck out any of those little tiny clots. And continued clinical follow-up. This is not a one-time thing. You're done and you're going home. That's it. No, this is something that needs to be followed up on, okay? Whether it be every 3 months, 6 months, a year, again, we tailor that to specifically to the patient. Patients need to be on blood thinning medications, where there's specific types, whether it's aspirin, Plavix, or something like Xarelto or Eliquis, Coumadin. We'll figure that aspect out, but we'll also help you with that as well. This is just a nice example of what is peripheral artery disease, okay? So this is a real-time x-ray, aka fluoroscopy, where I've injected contrast dye into the big artery in the abdomen called the aorta. And you can see where that yellow arrow is. Well, there's a complete cutoff. And if you look at the other side and compare it to the image on the other aspect of the screen, you can see those two arteries that are bifurcating or splitting off. Those are nice and plump and they look pretty good. That's because now I've put 2 stents in those arteries called the common iliac arteries, and now there's excellent blood flow going down into the legs. This is something that we see quite commonly in the lower extremities, okay? So this is actually the bones for anybody who, loves x-rays. This is the tibia and the fibula. And we injected contrast dye into these arteries. This is somebody, again, a typical type of patient. There's an ulcer. It's not healing, may need to be surgerized, may need to have a little amputation of the toe for whatever reason. And if you look at those red dotted lines, well, there's actually a void of arterial supply right there. And the way I usually describe this, whether it be arteries or veins, wherever there's a blockage, collateral blood supply likes to go around and try to get that blood back to where it needs to be. And this is why exercise is so important, because if you can't have an intervention for whatever reason, or you just haven't detected you even have PAD, when you're exercising, you're creating these collateral blood supply channels to other areas of the leg. The prime example that I use, again, for arteries or veins, is if you're driving down 880, there's a traffic jam, well, you can take some side streets. You'll eventually get to where you need to be. It's just going to take longer. So essentially what we want to do is we want to open up that traffic jam. We want to open up 880 so everybody can start flowing through that freeway as fast as possible. Okay, well, not as fast as possible, but stay in the speed limit. PSA. So essentially what we need to do with that red dotted line is we need to get a catheter in there. We need to open up that area with a balloon. And if you look on the image on the right, now you can see there's a nice channel between those 2 yellow arrows that this has opened up that freeway. Now the patient can start healing that ulcer. So let's switch gears a little. Venous disease. Let's talk about that. Again, arteries that we just talked about, which is peripheral artery disease. Now we're going to start talking about veins. And that's blood going from the legs up back towards the heart. So, well, what can venous disease entail? And this is abnormal muscle contraction. This is something that I talk about all the time to my patients is we lead especially right now, a sedentary lifestyle, sitting in front of the computer. We're doing work from home, whether it be Zoom meetings, paperwork, whatever it may be. We're doing a lot of in front of the computer work right now. And that means we're putting a lot of pressure on the back of our legs. We're having that blood supply not work for us. It's not pumping back towards the heart. So if you're just sitting there, you have maybe a long flight. You may be traveling to Australia. contract those calf muscles. And why does that work? Because the calf muscles, the veins are essentially going through the muscles. And when you're contracting the calf muscles, you're pushing that blood up back towards the heart, thereby helping you prevent getting blood clots. You may suffer from incompetent valves. That's part of venous disease. Arteries don't have valves, veins do, okay? So when blood tries to go from the legs up towards the abdomen, well, if you have incompetent valves, that blood may not stay in the abdomen. It may go backwards down into the legs, causing that swelling in the legs. Venous disease also includes thrombosis and obstruction. This can lead to vein dilation, skin abnormalities, and once again, ulcers. That's why it's really important to have a great physical exam in the office. Are these ulcers specifically related to venous disease or peripheral artery disease? We can help you figure that out. We're going to also talk about acute venous disease is often related to thromboembolic events. Okay, and what does that mean? Well, it means blood clots, thromboembolism. Chronic venous disease is present in up to 50% of individuals. A lot of people don't know they even suffer from it. And what is a typical thing that I hear about? Well, I've been walking around the house, I do some chores. By the end of the day, my legs get swollen and, I have to put my legs up and then I feel better. That may be a possibility that's related to venous disease. Yes, there are other reasons that this can occur. Maybe it's due to the heart, but a lot of instances, yes, it is related to venous disease. So what are the risk factors? Well, advanced aging, family history of venous disease, prolonged standing like we just talked about, increased BMI, smoking again, it comes into the legs, trauma, a prior thromboembolic event, hereditary conditions, high estrogen states, and pregnancy. So let's talk about acute venous disease. A lot of people know it by blood clots, that term. So when do blood clots happen? And one main example that we always talk about is that long transcontinental flight. Because you're sitting there, you're putting pressure on the back of your legs, and you're not moving for 10, 12 hours at a time. That blood is stagnant. Anytime blood becomes stagnant, it can be prone to developing blood clots. And then a thrombus is something, again, that forms in that one location. And if that thrombus were to break off and fly up, it's going to cause an embolism. One thing that I want to clarify here is generally, okay, we're talking about the majority of the cases, and there's a reason I'm saying majority. When a blood clot from the vein breaks off in the leg and it flies up into the, and I'm not going to give it away yet, but when it flies up into this area, it goes to the lungs. It does not typically go to the heart or to the brain. So let's clarify that. The only time, or one of the only times that happens, is if there's some sort of defect either in the heart or in the lungs, that it can cross over to the other side and then go to the brain. So that is it's a big kind of clarification right here, is blood clots from the legs, when they break off, they go to the lungs the majority of the time. Upwards of 600,000 Americans are affected by venous thromboembolism, VTE, each year. Let that sink in. That's a lot of people. And that's approximately 100,000 Americans will die of VTE each year. It's something that we don't even talk about. The only time that I've heard this come up in the news and that we've brought this up several times in the last year is because of the vaccines or because of COVID. And COVID, yes, it did lead to an increased thromboembolic event. Okay, but this is something that patients just suffer even without COVID times. 10 to 30% of people affected by VTE will die within 1 month of diagnosis. That's a lot of individuals. And it's roughly 25% of individuals who develop a PE. The first symptom is sudden death. So just think about that. Anytime, and I'll go over the symptoms as far as what a blood clot can appear as in the leg. You really want to make sure that you're looking at your legs every day and you're saying, well, is one leg more swollen than the other? Why do I have this pain? Is this pain because the arteries or the veins? Now, well, we've talked a little bit about the arteries, so let's figure out, well, what do the veins look like? And here we go, deep venous thrombosis, or a DVT. Symptoms, pain. You may have unilateral leg pain. Oh, my calf is hurting. The behind my knee, that is typical. Behind my knee is hurting. It's really bad. It just happened all of a sudden. I'm not sure why. And then all of a sudden, I just became really tender. My leg is swollen. I really don't know why. It looks a little red. I notice it's a little bit bigger than the other side. Start thinking about that. Anytime you have unilateral swelling in the legs, that's something to be concerned about, and that's something you need to bring up to your physician. It may be warm to touch as well. And why is that? Well, because you have an accumulation of blood in that leg. That blood really can't go anywhere because there's a blockage. So that blood, that warm blood, may start leading to a warm to touch leg. So acute venous disease, how can an interventional radiologist help? Well, we can start talking about clot removal. This is essentially a venogram, aka I put a catheter in one of the veins and I injected some contrast dye and I took some real-time x-ray images. That yellow arrow on the left, that should be a nice channel going up towards the top of the screen, but you don't see that. You see some irregular wavy veins, you see a blockage right there, and that is a DVT, deep venous thrombosis. And essentially, what can I do? Well, I have a couple of different devices that I can use. One, again, is essentially a vacuum cleaner for the veins. The other, we can drip some medication, which is a clot-busting medication, and we can really clear up those veins. And you may be asking yourself, well, what is that funny looking umbrella thing on the top of the screen? Okay, that is an IVC filter. That's what I was alluding to before, those late night infomercials when they talk about, do you have an IVC filter that's been placed 10 years ago? This is something that essentially needs to come out. And what is this? Well, this is something that you may have put in for one of many reasons. And it may have had a blood clot in the legs that you may have not noticed or knew about, and you had some sort of other issue that you're in the hospital for. Maybe a GI bleed, some sort of bleeding risk that you had. And we had to place an IVC filter in the vein because we didn't want that blood clot to break off and fly to the lungs. So we placed this little protective device, which looks like a little umbrella, which is an IVC filter. And we wanted to stop any of those blood clots flying up into the lungs. Again, they go to the lungs, not usually to the brain or the heart. But again, these filters need to come out because over time, they can actually cause blood clots themselves. So it's a catch-22 with these. So used to, in the day, they would put these in permanently, but all these filters that we place now are temporary. So again, we can talk to you about that in clinic. This is the arrow that I was alluding to right here, which is that IVC filter. Pulmonary embolism, again, an embolic event is a thrombus that has broken off from the legs or even the arms. You can get DVTs, and it has flown to the lungs. Pulmonary, that's where that word comes from. So patients may experience shortness of breath, some chest pain, some lightheadedness. They may have this sign of impending doom, how they like to talk about it in textbooks. May have a fast heart rate or tachycardia. And they may just, say, oh, I have this dry cough that I haven't been able to get rid of. Well, if you look at that arrow right there, this is the pulmonary arteries, that nice kind of bright triangular looking thing where it looks like two legs. But there's a blockage where that arrow is, and that's what a pulmonary embolism is. Again, what can an interventional radiologist do? Well, essentially, I can get a catheter into the area. I can put in that suctioning device, take out the blood clot in there. And, well, it takes about an hour. There's no more blood clot. And if you look at the image on the right, that arrow now signifies a wide open pulmonary artery. And also, I want you to take on the subtle clues here. And that image in the middle, which is that real-time x-ray, that fluoroscopic image, the lung that has all the spidery webs kind of arteries, that's nice and opacified, or that's brighter. And if you look at the other side, you just don't have those spider webs going towards the ends of the lungs because there's no perfusion there. If there's a lack of perfusion, there's a lack of blood supply exchanging with each other in the lungs, and that's going to mean there's a lack of blood supply going back towards the heart. Let's talk about chronic venous disease. So reminder, what is chronic venous disease and what can that entail? It can be because of abnormal muscle contraction, incompetent valves, thrombosis, obstruction, and it can lead to vein dilation, skin abnormalities, and once again, ulcers. These are the symptoms. You may experience these. Some people may have these. They just haven't really thought about them, and it may just be there. Telangiectasias, these little spider web looking things. You can have varicose veins, reticular veins, leg edema. You can see how a clinician is pressing into the leg and it's indented itself, and it takes a couple of seconds for that indentation to go back to normal. Skin discoloration, and again, skin ulcers. So this is kind of the spectrum of chronic venous disease that we deal with on a daily basis here. And again, stages of varicose veins. So you can see the normal legs on the left, and then as you see the schematic going towards the right, you can see stage 4 where these varicose veins, the skin discoloration, the ulcers have really developed. So you really want to make sure you're not getting to that stage. If you may be in stage 1 where you see maybe some reticular veins, maybe some spider veins or telangiectasias, you may want to start, say, oh, let's go talk about it with my physician. Let's go see, is this something that can be treated? Or why do I even have this? Is there an obstruction going on inside? Do I have these incompetent valves? Why are these even occurring? What is the next step? Always comes back to a physical examination. Absolutely, number 1, non-invasive, easy to do. Let's just see what everything looks like. Are these truly varicose veins? Is this due to something else? Is there an infection going on? Is that truly an infection or skin discoloration? Let's figure that out and tease out those options first. And then a detailed medical history. Well, you may have told me, well, about 20 years ago, I remember I had some sort of blood clot. I went on some sort of blood thinning medication, and now I take oral contraceptive pills. Well, those are something that are actually completely intertwined with each other. Oral contraceptive pills can lead to blood clots. So we really want to have a detailed medical history about what's going on. And then it always comes down to medical optimization, okay? You may have a heart condition that's causing blood not to really pump to the body as well as it should. Are you taking that water pill? Should you be taking more of a water pill? Is the edema or the leg swelling related to the heart, or is it related to those incompetent valves? And then what can you ask your IR doctor? Well, do I have chronic venous disease? Everything that we talked about, we can go over that with each other in clinic. And then what is truly the cause of my disease? Is it the heart? Is it the lungs? Is it actually the legs? Is there something going on inside my abdomen? What's the deal? Why do I have this? And then what medications should I be taking? Should I be taking this water pill? Should I be taking other medications for this leg swelling? What should I do? Compression stockings, that's the next one. Should I be wearing compression stockings? Which ones are the best? What grade should I have? Should they be going up to the knee? Should they be going up to the thigh? Which ones are better? How long should I be wearing compression stockings? If you have leg swelling, it's probably a good idea to do it. And then, do I need an intervention? Of course, I'm going to say it, a minimally invasive intervention. Is that something that you want to go forward with? We can talk about that as well. And then, do I need to have my IVC filter removed? Why did I even have it in the first place? Is it removable? Is it permanent? Is it temporary? Let's talk about that as well. Let's also talk about lower extremity duplex ultrasound and venous insufficiency. Okay, so what does that mean? That means basically the blood that should be going up towards the abdomen, towards the heart, well, it's going the other way. The veins and the valves are insufficient. They're just not good at pumping blood up towards the body, and they're becoming incompetent, and the blood is falling back down into the legs. Well, this is an ultrasound study that we can perform quick and easy, outpatient basis. You just come into our ultrasound department, have your legs scanned, and then we can talk about potentially a vein ablation. And what does that mean? Well, you have different types of veins in the legs. You have the deep veins, and then you have the superficial veins. Are the superficial veins something that we can just get rid of? And those are something that, usually should be working in the majority of the population, but just in you, it's just not working. Well, in outpatient procedure, we can quite literally just get a little catheter into that vein and burn that vein shut, or we can inject a little bit of material in there that will just clog up that vein. You don't need to worry about it anymore. Chronic venous disease, you have to talk about obstruction as well. There may be something that's going on inside the abdomen. This is a venogram, aka injecting contrast dye into the pelvis, and there's some sort of compression in this instance causing the vein to become very tight. That's what's causing the leg swelling in this instance. And one stent later, it's about an hour procedure, put a balloon in there, opened up that stent, now the blood flowing nicely through that area. And these are the arrows showing the stent. So in summary, interventional radiology plays a vital role in not only the diagnosis of peripheral artery disease and venous thromboembolic disease, but it also is key to swift intervention in minimally invasive procedures. So I thank you very much. I know that's a lot of information to cover, and I hope so you guys got something out of this. Please feel free. Give us a call anytime at our office, 510-818-7362. Happy to answer any questions.
Thank you, Dr. Hansra. I do have a question. I have symptoms of PAD. Do I see my primary first or for a referral, or do I go straight to your office?
That is a great question, and I am happy to see you straight in our office. That's not a problem. The phone number is here. Feel free to call us. We have the best staff. They can coordinate everything for you. But if you'd like to go through your primary care physician first, that's not a problem as well. It's always great to have a primary care physician involved where he can help coordinate. Again, is this medical management completely optimized? Is this truly PAD, or is there statin? Does that need to be bumped up? Does the Lasix that you're taking, the water pill, does that need to be bumped up? So it's also really nice to have this kind of collaboration.
Will I be awake during my procedure or will I receive general anesthesia?
So the majority of procedures that we perform are with moderate sedation, as we call twilight sedation. We usually give a narcotic and a relaxant for our procedures. And you're in a type of twilight state where you may fall asleep, you may wake up, you may likely not remember the procedure at all, or you may just want to have a conversation with me. I have a lot of patients where I'm on the table performing the procedure, we're talking to each other, and we're looking at the images, whatever I'm looking at, the patient's looking at, and we're conversing. We're saying, yep, your catheter's right here, this is where the blockage is, this is where we're going to open up. So it's really tailored to the patient. Majority of the time, moderate sedation is enough. There are a few instances where we do use general anesthesia.
How soon can I leave the hospital after my procedure, and what is the recovery time?
Yeah, for these procedures, the main recovery point for these procedures, number one, we want to make sure the sedation has worn off by the time you've left the hospital. Again, the majority of these cases are an outpatient basis. And we also want to make sure that artery, wherever I entered, has closed up nicely. Again, if it's in the artery in the groin or in the wrist, we use different types of devices to close up that artery. At most, it usually takes about 4 hours after the procedure has been completed for you to be discharged afterwards.
Should I continue taking my regular medication before my procedure?
And it depends on what type of medication that we're talking about. So if it's a blood thinning medication, Eliquis, Xarelto, Coumadin, aspirin, Plavix, one of those, when you come see me in consult, I'll talk to you and say, you know what, let's stop the aspirin for about 5 days beforehand. Plavix, yeah, let's give it about 5 days. Oh, you're on Eliquis, let's give it about 2 days. So I'll really tailor that to what type of procedure that it is. If it's your blood pressure medication, your statin, your water pill, we usually just say continue taking as such.
Okay, and our last question. How safe is it to have a procedure done at Washington Hospital?
Absolutely. It is. I appreciate being here. I enjoy working here. As you can tell, wearing the mask currently, we have catered to a very safe environment here. Staff and we are always cognizant about what's going on in the world right now. We do require a COVID test before our procedures. We always tell our patients that. We help them schedule it basically beforehand within 3 days, and we lead to a very friendly environment when it comes to COVID precautions.
This concludes our program. Thank you, Dr. Hansra, for your expertise, and thank you to our viewers for tuning in. The entire broadcast of this evening's event will be available on Facebook and YouTube.